We are 13 million nurses in the world. 13 million nurses. But not a single one of us sits, for example, on some of these high impact decision-making tables.
You're listening to Patterns and Meaning, a podcast by Seed Global Health. We find meaning in patterns, connect history to the present, and illuminate the way forward in global health. I am your host, Edem Tokuno. Today in the guest chair, we have the phenomenal Judy Khanyola. Judy is a recognized nursing leader with over 25 years experience in clinical nursing and education programs. She has led HIV programs and provided technical support to NGOs and the public sector, working with partners in Ministries of Health in multiple countries across East, West, and Southern Africa. Judy is currently the chair of the Center for Nursing and Midwifery at the University of Global Health Equity. My first question is, why is the topic of decolonizing global health so important to you as a nursing professional based in Rwanda and on the African continent?
I think for me, it's important because the narrative has been shaped by people outside Africa, and coming to where we are now in 2020, it's clear that very many things have not worked. And to me, I think one of the reasons, of course, there are internal reasons to us in Africa, but I think decolonizing health is one of the contributing factors to this, in the sense that when someone else shapes your narrative, it's never going to work well. It may look like it's working, but somewhere down the line, you're going to see that, no, it's not working. And I think, we're in 2020. Yes, this is the year of the nurse and the midwife, and we're happy about that. But, even the coronavirus has just shown us so starkly the inequities and the disparities that we face in Africa. In nursing, of course, as a health profession, we are the largest, numbers in terms of sheer numbers of the health workforce. But even there, you find that we are not well represented. And these are carryovers or hangovers from past legacies, of which racism is one, colonialism is one. It's followed by neocolonialism, issues around paternalism that is still a big thing here in Africa, patriarchy, which is still a big thing here in Africa. All of these have combined to bring us to where we are now. And I think for us to move forward in a meaningful way, we need to address some of these issues, understand them, and begin to correct the narrative moving forward.
I like that you said correct the narrative moving forward, because my next question is, in what ways have colonial and neo-colonial influences shaped global health, from curriculum development and training, program and policy, and even funding?
I think for me, again, during colonialism, we were colonized, and because of that, African peoples did not build the fabric of their countries. Even the countries that we are in now, I remember my history well. Lancaster, was it 1888 Lancaster Conference, that divided, split, scrambled. It's called the Scramble for Africa, and they split it they just drew arbitrary lines on a paper over in Lancaster in the UK for us here in Africa. So you find that a line is drawn. I come from a community, I'm married into a community in Kenya that is the same community in Uganda. So the border was drawn, and literally it drew a line between a sitting room and a bedroom of a home, so that the bedroom fell into Uganda and the sitting room is in Kenya. But these are the same people. But now, because of that, what I'm trying to say is that then made everything going forward was wrong. And more so now in health. We inherited, for example, I keep saying, a biomedical model that came into Africa that then said that everything that was there before is bad, is heathen, is pagan, is savage. Africa is called the dark continent. So everything that came out of there was nothing good that was then seen, because these people who came from outside came with the idea that whatever was there is wrong, and we had to change that. So we lost a lot of what made us who we are. And I think that loss is what somehow subtly contributes to some of the challenges. So that's sort of answering your issue around why is it now so important. There are all these words that have now come out as a result of that. I hear this term called white saviorism, but it's really true when we say that, because then still having that hangover that nothing in Africa is good. We need to be helped. We need to be saved. So that has come into the curriculum. For example, we mentioned, I remember in the webinar about childbirth and the fact that now with the biomedical model, women are made to lie in the lithotomy position to give birth. And we know that, and increasingly understand, even from a scientific point of view, that that's not the best way for a woman to give birth. Traditionally in Africa, we used to squat. Two women would hold you, you'd squat, and with the pull of gravity, the baby would come out. It puts less strain. There's no oxygen deprivation, etc., etc. It's also something that's culturally, we even had the birthing stools that we had, but now no, those are heathen. Put somebody in the stirrups, lithotomy, put your legs, push, because this was the biomedical model that we inherited from the colonial masters and the people who entered our lands. And so I think for me, these are the things we need to change. They come into our curriculum. When I did my midwifery, we had Margaret Miles, and that's what we are taught. So I know how to deliver a baby using that particular method as a midwife. When I'm helping a woman in labor, she's traditionally made to lie down. And, we know that these positions are not efficacious or optimal for women in labor. And we had these practices in Africa, which were very good, which somehow, I said last time, we threw out the baby with the bath water. It is not to say that everything in Africa is good. It's not to say that we didn't have wrong things or do wrong things or carry out wrong practices, but we need to look at ourselves and say we had a lot of good that we should have kept and improved on. So in terms of even our curricula, inheriting that biomedical model of learning and studying and caring for our health profession, we, I think, need to go back to the drawing board.
We do. And in line with the divisions, you mentioned like the divisions were literally putting a break in between the bedroom and the sitting room, between like Kenya and Uganda. This also came with languages being basically dropped onto us. And now we have Anglophone and Francophone and Lusophone countries. And during the webinars, you talked about the importance of language and how the loss of our language due to colonialism and the division into the different language borders has hindered our ability to communicate with each other. So how does this impact health practice and eventually health outcomes across the continent?
So when we look at language, for example, because again, we inherited colonial masters' language, we lost our language. But you find that here in Africa, not very many people can speak this colonial masters' language. I come from Kenya, and so here we were colonized by the British, so we speak English. I speak very good English. And my grandmother, for example, can't speak English. She speaks her local language or vernacular, Many people in the rural parts of Africa can't speak that colonial language, whether it's English or French. So if I'm a nurse and I am going to look after somebody like my grandmother, how would I do that? That's just the answer. Because she's going to speak in a language, I'm going to speak to her in a language that I'm telling her things from the colonial master's language, which sometimes may not really resonate with her. And so already that's a barrier in terms of healthcare delivery. You cannot treat somebody without talking to them, without communicating with them, without understanding them. We take a lot of assumptions as a result of that when we are delivering our healthcare. And those assumptions then lead to sometimes substandard care, sometimes even, I want to say, things that go wrong, because we didn't understand one another. So language does play a big part. The other thing, of course, is that these divisions have then made us as Africans also not talk to each other, apart from now internally in Kenya. So I speak English, I'm treating somebody who doesn't speak English. So already as a nurse, just as a nurse, I have to find a way to communicate. And in that process, something gets lost in the translation that then means the care that I give is less than optimal. But then also between me and you, Adam, are Anglophone because Ghana was also colonized by the British. So that's why we are talking now. But if you are from DRC, we would not be having this podcast. You would not be able to understand me unless we have a translator who speaks French and then translates French into English, English into French. So again, based on that as Africa, then you find that we have schisms within the continent, which make it very difficult to trade, to learn from one another, to, see what each other is doing. Because when I think of which country do I want to go to, the first thing is I want to go to a country where at least I can make my way around. So I may never go to Kinshasa. I may never go to Yaoundé in Cameroon because I'm thinking, I don't speak French. Or I may never go to Mozambique. I don't speak, at least I speak French, basic French. I don't speak any Portuguese, So then how do I go to Mozambique, which is just not very far away from where I'm sitting now? How do I go to Angola? How does an Angolan come to Kenya, to Nairobi, or to Accra, Ghana? Or how does somebody from Mali and Togo meet with somebody from Uganda and Tanzania or Malawi? So again, as a continent, I think we have really lost a lot as a result of these schisms that have been brought about by language. And of course, again, language is part and parcel of you as a human being. It's part of your culture. So the fact that in fact, we often laugh when we are amongst us as Africans. We always say, you speak, then you want to say something and you're like, what's the word for this in English? I know it in my mother tongue, I know it in vernacular. So sometimes I say, in vernacular, we'd say it like this. But when I translate that, you don't get the flavor and the essence of what it is I'm saying. Maybe I'm cracking a joke, or maybe, and that's why you find a lot of like the proverbs. Sometimes in Africa, we just go back to the proverbs. You're like, there's a proverb that says, the fly that does not leave the coffin gets buried in the coffin, buried with the body. But when you say it in vernacular, the essence of it comes out. So again, we've lost a lot of that as a result of language, and that impacts things like, for example, sitting at decision-making tables. I always say one of the inequalities that colonialism and racism brings is we are not able to sit at decision-making tables. I'll speak for myself as a nurse. Very rarely will you find a nurse at a top decision-making global table. So I'm talking about here, WHO, Global Fund, International Aid Society, for example. I think we've just gotten this year the first nurse sitting on the International Aid Society table, making decisions around HIV policy and things like that.
So then how do we foster stronger collaborations and shared learning and ensure that communities have access to high quality care despite the language barriers?
So I think one of the things we can do, and we are doing now, is begin to talk. And I say that, conversations, discussions, this discourse that we're having is the beginning of a good thing, because one, we're able to understand things from others' perspectives. If I listen to you, Adam, I'm able to know what you think, what you feel, what your motivations are. So already that is a good thing. And I think the globalization of our our Earth, our planet is beginning to make people see that there is another way of doing things when we see this, because then we can now see, for example, in the United States, recently we've elected a biracial woman, which I think is unprecedented in my view. So for me, I looked at her and I'm like, wow, she's a woman, so I was so happy. But then she's also black or brown. And I like that as well. It sort of begins to now help us see that these people are not the enemy, because sometimes if a lot of things which were done by white Anglo-Saxon Protestants, we look at a black African woman such as myself as the enemy. But now you're like, no, we can talk. So discourse, I think, is the first thing, and continually looking for avenues and fora to do that is one good thing. There's something that's called reverse innovation, where this is now going to undo the white saviorism complex that I mentioned earlier, where we're looking and saying we can learn from each other. So it's not about the white coming to the white saviors or the global north coming to save us in the global south, but us learning from each other. So there is a lot that we in Africa can teach the rest of the world if given a chance, if we push that narrative, if we are sitting in spaces such as now I am here and telling people there is a lot you can learn from nurses in Africa, from the nursing and midwifery profession in Africa, and people can. And I've done a lot of this during this Corona time virtually, and a lot of the feedback I've gotten is people are like, I didn't know this, Judy. I'm so happy you said this. How can we work together? And often when I see that, I'm like, we are not enemies. I think all of us, we are first and foremost human beings. We all have desires and wishes and motivations. And once that begins to happen, people say, how can we work together? I'm like, that's how we start doing it. It's not about you coming to help me, but it's how can we work together, despite the challenges that are there. I'm not saying they're none, they're there, but we can surmount them if we have the wherewithal and the goodwill, the initial wish to do it together. One of the other things that we can do is change our just the way we do business. So, for example, we have a lot of people come into Africa, get data for research, and then publish it as themselves. But the data is from Africa. And we are saying, no, we don't want this information that comes from us being taken somewhere else. And then, you're told, in Africa, everybody's dying of malaria. So we don't want that type of research that portrays us in a very negative light. Yes, I do know we have malaria, and yes, I know people die of malaria. But if I'm the researcher, I want to look at it from my perspective. Can I be allowed that? So again, it's beginning to change the way even the research question is phrased. I'm not interested in the number of babies who die of malaria. My government collects that and is supposed to collect and do something about that. So perhaps I'm interested in some of the factors that contribute to children dying of malaria from an African point of view. Is it nutrition? Is it family dynamics? Is it, even the climate? Somebody mentioned, I read somewhere that Africa is paying the price for climate change that has been caused by countries in the global north. We are now having floods and all of that, a result of that activity happening, again, demonstrating the skewedness of our world. So I think just, those are some of the things. We are 13 million nurses in the world, 13 million nurses, but not a single one of us sits, for example, on some of these high impact decision-making tables. So we need to now say, can we allow for this? Can we have, I want to call it, what is the word, where they say, they give you a chance. What do you call it? If you want to go to college, and they have a slot for a black child or a slot for a woman. Well, I mean, make concerted efforts to say that if we have these global decisions, at least one slot should have a nurse. One slot should have a nurse from Africa, so that you can have a nurse. But if she's a nurse again from the West and she's speaking from her perspective, I'm happy that she's a nurse because I'm like, hey, at least our voice is being heard. But in future, I really like to see a black nurse, so that is another area we can consciously put to make sure that our voice is heard and our narrative is put forward.
I think the phrase is affirmative action. Is that what you were looking for?
Yes, thank you. Affirmative action. That's the right word. You're right. Yes. Yeah, absolutely.
Okay. Thank you so much, Judy. When during the webinars, you mentioned that poverty, war, corruption, and disease are the 4 horsemen of the apocalypse that are associated with Africa. And this has brought a lot of attention to the continent and has curiously resulted in Western celebrities becoming the face and voice of the continent. So very much in line with the white saviorism. So how does the prevailing narrative affect Western global health practitioners? How does it affect how they would interact with the countries they partner with and the communities they serve? And how does it determine who gets to be considered a global health expert?
So I think for me, like I said, we built health systems based on Western celebrities. And the face of Africa often is Bono or Elton John or Princess Diana with landmines in Angola, or I don't know, Meghan Markle even, I don't know. I'm being facetious, but that's often how long it's been. And I think it's important for us to first of all, again, look towards, how can I put it, understanding what is in Africa. We need to first not come with the idea that I'm coming with a solution. So a global practitioner has to be somebody first who is humble, who first wants to learn, who wants to take time to understand the context of where we are. I've been involved in a lot of project work, funded by external donors like, Bill and Melinda Gates Foundation or, PEPFAR and NIH and so on and so forth. We do a lot of that in Africa. I'm working on an NIH grant. I'm working on a PEPFAR. I'm working on CHAI or whatever it is, which is not bad in and of itself. But often these priorities, again, are made somewhere outside Africa with the thing that, there's HIV, it's killing people. So let's come quickly and give them drugs. And then 5 years later, you find why isn't this working? It's because you didn't even understand the context in the first place. So if we can find a way to begin to first work towards understanding what's the context that we are in, what are the challenges, and you can only do that when you come and specifically look at what is on the ground and understand. If you can't do that, then get somebody who understands what is on the ground. And often it cannot be a white Anglo-Saxon Protestant who is telling us about what should happen in a remote village in Kisumu, Kenya, or in Mzuzu, Malawi, or in KwaZulu-Natal in South Africa. We need to know we need to have these people speaking about what their issues are. There's a phrase, nothing for us without us. So that has to be the first starting point for me to say I'm a global practitioner. I, Judy, cannot attempt to come to the United States or to the UK and purport to imagine I understand I am the panacea to the problems that they face, because I don't understand their culture. I don't understand their history. I don't understand what their space. So why do we feel that when the whites come to Africa that they just have an answer for us? And you come in for 5 years, you come and say, build wells, and you build wells and you leave. And then you get surprised that the women didn't use the wells because that is not what they wanted. And you did not understand what they wanted. So all of this, again, comes from the point of view of really, I think, to me, being authentic or genuine if you really want. But to me, again, and I want to move away from this thing of people coming into Africa to help us. We need to help ourselves. And here and I turn the lens away from the whites and look at us as blacks or as Africans, that we are the only people who can make a conscious, concerted, and fundamental, deliberate change that will be sustainable for the generations to come. If we want to what do you call it? To eradicate malaria, it's only us who can eradicate malaria. It is not Bill and Melinda Gates Foundation. It is not the Global Fund to fight HIV, AIDS, and malaria. It is not PEPFAR funds from the United States or DFID funds from the UK. It is us Africans. It is me. It is you who live in Africa, in Accra, in Nairobi, in Kampala, in Dar es Salaam. It's us to sit and look and say, what can we do to change, and then plan forward. Obviously, you can never do everything by yourself. There's nothing wrong with working together, or how can I say, even asking for help for that matter. But when I ask for the help, it is that with the understanding that what we are going to implement is something that is sustainable and beneficial and culturally contextual for those people. Again, I'll refer like to curricula as a nurse and as a teacher now, that our curricula needs to actually be responsive to the sicknesses and the challenges and the communities that we will then practice in. If I learn my nursing in Africa should be focused on what Africa is all about. It should not be a cut and paste of Canada or UK or US or Germany, because that can never work. And that's where you see the disconnection and the disjoint and the lack of tangible impact of all these interventions in the last decades,
Two things I've picked out of this, and in summary is, one, we need to be intentional about the content. Like when it comes to curriculum, we need to be intentional about owning what the content is, and it must pertain to us, the kind of diseases and things that come up here, and our solutions to them. And then number two is that we need to insist on being the custodians of our own stories, and we need to insist on telling it and talking about the solutions as well.
Another thing in addition is we need to hold sincerely, I think we need to hold our leaders in Africa more accountable than we are. We've given them a free pass to just plunder our resources, and not just the minerals that Africa has, but even our intellectual resources. So if our leaders can look at what I'm doing, even if it's one thing, it should benefit the whole community. It should benefit 50 million Kenyans. It should benefit 60 million Tanzanians. It should benefit 100 million Ethiopians. It should benefit 200 million Nigerians. It should not benefit 5 people in Nigeria who are the president and the deputy president and 5 ministers. It should benefit the whole of Zimbabwe, not just the first family. So again, a lot of that can be done by us as the populace to hold our leaders accountable. We pay taxes. So why don't our health facilities have medicines? Why don't we have CT scan machines? Why don't we have linear accelerators for radiotherapy for cancer that is killing us? Why don't we have chemotherapy? Why don't we have nurses getting paid? Why do we have doctors dying in corona now? Because they don't have PPEs. These are questions that nobody from outside can come and answer except ourselves, to answer for ourselves. We need to collect data, and that's one of the things I'm now working with some of the nursing leaders in Africa to collect data about things like, for example, how many nurses are on policy decision-making tables, How many nurses are in positions of responsibility without authority, giving me increasing responsibility and no authority, so I can't make decisions. I don't have a budget. How many government chief nursing officers have a budget for the nurses that are the majority in their countries? I bet even in Ghana, your Ghanaian chief nursing officer probably doesn't have a budget that she is accountable for, that she can say, I get $1 million every year to manage nursing in Ghana. And then we can take her to task. What have you done with this money? Most likely she doesn't. So she is forced to just do stuff, but she does not have the authority. And then when things go wrong, they'll come back and say, oh, nurses are bad, oh, doctors are bad, oh, the health system is broken. So these are questions that only we ourselves can task our leaders to answer. We cannot expect anybody from outside to come and answer these questions or make these changes for us.
I'm glad that you talked about the budgets and basically putting resources into the healthcare system. So from your perspective, what does investing in health look like? How do we hold leaders who are for too long have been bent to the will of donors to the detriment of their communities accountable? How do we hold them accountable and make sure that they give the leadership of nurses the budget to do the work they need to do, and that they are investing properly in the healthcare system?
I think, again, to me, I always say this starts with us nurses demonstrating our competence. with us nurses demonstrating our wisdom, with us nurses demonstrating our expertise, with us nurses demonstrating our skills, knowledge, first and foremost. So there is no way somebody is going to allow me to sit on a policy making table if I don't demonstrate that competency. So that is all on me. And I keep telling my nursing colleagues, if you're not going to study, you're not going to read, you're not going to skill yourself, don't imagine somebody will wake up and just say, we have made you the chief nurse, we have made you the head, we have made you the boss. That is not going to happen. So I first, as Judy, has to sharpen myself. Then now that I'm sharpened, wherever I am, I'm in a position of leadership. Then I must be able to make decisions that are for the nurses, not for me. It's not about me. It's not about my face. It's not about what I say. Two, and again, I keep saying, I keep pushing the agenda that we must put our leaders to task. We have the Abuja Declaration that gave 15% of GDP on health. Very few countries have achieved this in Africa, maybe only one or two, I think, if my memory serves. And you find that many African countries, therefore, don't put the budget. Without resources, we can't do anything. I can talk and talk and talk here or shout and shout and shout, but without resources to train nurses, these nurses need to be trained. They need to be competent. If I sit somewhere and I say, I am training oncology nurses, then we know in Kenya, in Rwanda, in Malawi, in Ghana, we have a pool of trained oncology nurses to manage cancer. These nurses need to be paid. First of all, you need to train them. That takes money. They need then, once they're trained, to be absorbed and paid for their specialized skills. These are the things I would want to do if I was in a position of leadership, to make sure that we don't then kill the morale of this well-trained oncology nurse who is fighting cancer in her village and is paid $40 a month or $100 a month. And you expect her to keep doing this work selflessly. It doesn't work that way. So for me, it's very, very important that we get onto these decision-making tables and push our way. And we need to then, when we get onto the table, be able to speak. Because you can be on the table, but you're saying nothing. Maybe you're just drinking tea and dreaming of tea break. And when the day ends, you go home and you've not done anything meaningful or beneficial for the constituency that you're serving when you sit on that table. The other thing I think we need to do is work, and I am, sitting here as the chair for the Center of Nursing and Midwifery at the university here in Rwanda, to train nurses so that we have competent, skilled practitioners. That's what Africa needs. When a child has malaria, you have to take care of that child. You have to make sure that child gets well. In order to do this, you have to go to school to know what to do when a child gets malaria, when a child gets pneumonia. I've vaccinated so many millions and thousands of children over the course of my life. I know what vaccination means. I know the importance of vaccination. I have to do it well so that I can say, our children are vaccinated 100% from certain childhood illnesses, etc., etc. So a combination of many things will slowly begin to change this narrative.
Are there any pattern words, or is this something that you'd like to say, one to leadership, to that you have not said already, to your colleagues, and then to someone like me who is a stakeholder in the healthcare system, but I do not work there as a professional, but I am a recipient and I take from the healthcare industry?
For you who's a recipient, please take your health practitioner, hold your health practitioner accountable. So you also have to have knowledge, okay? That's number one, because when the people we serve hold us accountable, it sharpens us. If I know I'm going into a class with very bright students, I'm not going to just enter there with old notes and just spew stuff. I have to read, I have to research, I have to sharpen myself in order to then be able to be at par and make sure that my students are, I'm giving the best to my students. If I'm a nurse and, I have to know what it means to take a temperature of a child with a fever, what does that mean? And if that child convulses then as a result of that fever, what do I do? So I can't just take things lightly. I have to keep on, like I've said, sharpening myself. So if the people who come to us hold us accountable, it makes us who deliver the health services that much more better. But over and above, I can be the most competent nurse, but if I don't have a thermometer, I probably can't take your temperature. If I don't have a blood pressure machine, I can't know what your blood pressure is. And again, these are systemic issues we have to challenge. Is there resources to make sure that healthcare workers, when they are practicing and giving their health, are equipped to do a good job? I think another issue that can help is things like the media. Often the reporting that comes out from the media, and this is something we need to deliberately correct about Africa. It's not about floods, famine, poverty, death, war, children with flies on their faces. There's another Africa that we want to show. There's another Africa that we need to put in people's minds that is the correct one. Because even with Corona, I've seen a lot of narratives that are asking, why is Africa not dying of Corona like the West? Like, that thing puzzled me. I'm like, why are you asking that question? What is it? Because they thought we are going to die like flies. And so because we are not dying like flies, there's an anomaly. And that's because you have this inherent thinking that everything bad must happen in Africa. So when bad things don't happen in Africa, then there must be some supernatural occurrence. And it can't be that. Perhaps we've managed the pandemic better than you have in the West. Perhaps we put in place things on the ground better than you have in the West. And could that really be the reason that we did a better job? And nobody wants to say that, the reason can be that they're actually doing a better job in managing. The reason is the sun. It's very hot. Something supernatural has to have happened in Africa. That's why we are not dying in the millions that we are seeing in Europe and in the United States. And so to me, the media also helps to shape this narrative. We as Africans have to step up to the plate. We need to research. We need to get data. We need to read widely. We need to push back on things that are not right, as leaders especially. So if somebody comes and they are giving you a loan, is this loan beneficial to the whole country if you take a loan to build a road? Or is it just benefiting specific people for that season? And 25 years later, my grandchildren are the ones still paying this loan of a road that was built on terms and conditions that were not beneficial to us. So again, I think a combination of many things, but I want to say the buck ends with us in Africa. I want to say 95% the buck stops with us. We cannot keep on blaming the West. We ourselves have to, step up to the plate and trade and make things that are beneficial to us. One of the things I've seen here that's happening in Rwanda around trade, which is just showing that imbalance, is that Rwanda has refused the AGOA Pact, Africa Growth and Opportunities Act that sort of gave us, because they said we don't want to import secondhand clothes. We want to build our own textile industry. And because the West was sort of, I want to say, lording it over us, not quite lording, but the terms were skewed in their favor, somebody has sat and changed that and said, no, we will not allow this. We want something that is beneficial for us. And I think if more and more leaders in whichever sphere, so for me as a nursing leader, what I'm doing should be benefiting the people who are sick. As a nurse, if I go home every day, people who've come into contact with me should go home better because of interfacing with me. So it should be my work as a nurse is to make people well and make the whole person well, and do this with, care, compassion, and the skills and the knowledge at my disposal. So I cannot be happy if people, when they meet with me, go away sad. And that would break my heart as a nurse. So that's what I'm telling our leaders. If you're the president, you're the minister for health, you're the head of the hospital, you're the head of the unit, is what you're doing helping us in Africa, or is it hindering? I think those are things that we need to begin to seriously deliberate on and work together to move forward.
Thank you so much, Judy. This has been a very insightful conversation as always, and looking forward to more opportunities to hear your thoughts on decolonizing health and just like overhauling the healthcare system and building making proper change and building our institutions, our health institutions. So thank you very much for your time.
Thank you so much, Adam. I will just keep on rooting and saying, please invest deliberately in nursing. For me, I believe this will be a game changer for the population's health here in Africa and beyond. So thank you very much for giving me this opportunity to just share my thoughts. Thank you so much.
And there we have it, folks. Like Judy said, let's invest in nursing. Let's be more intentional about owning our curricula and making sure that it pertains to us and contains solutions that come from us, because we need to insist on being the custodians of our own stories. Let's hold our leaders more accountable than we're currently doing, and let's collect more data. We've linked to the webinars mentioned in the podcast in the show notes, so you can check it out there if you're interested in them. Thank you.